Hello, hi. Thank you for the opportunity to speak at ISICEM. I'm Chou, and I will be speaking to you about COVID-19 neurological manifestations and impact on the brain. I don't have any significant disclosures other than to say that I'm funded by a government grant to do this work. And the objectives of this talk is to discuss what is known about the neurological manifestations and brain involvement of COVID-19 and identify critical knowledge gaps. And then I will briefly talk about what we're doing to address this knowledge gap. As we all know, COVID-19 is a pandemic of historic proportions. As of yesterday, there are 24 million cases around the world. In a pandemic like this, even if the neurological manifestations is only 1% of all of the patients infected, that is still a huge public health crisis. And currently, we do not know how many patients will have neurological manifestations. Why do we suspect that there could be neurological or central nervous system involvement? Well, the truth is, many prior pandemics have had CNS involvement. Take the seasonal flu, for example, by influenza. Even though most patients don't have a neurological problem, cases such as acute necrotizing encephalopathy, acute infantile encephalopathy, and acute hemorrhagic leukoencephalopathy and myelopathies have all been reported, and these are very, very severe neurological syndromes. The seasonal cold, which is carried by human coronavirus, a different coronavirus than SARS-CoV-2, has caused encephalitis in infants, acute disseminated encephalomyelitis in children. As we know, in 2002 and 2003, the original SARS pandemic took over the world. And with this virus, patients have developed encephalopathy, seizures, and we've found this virus in the cerebrospinal fluid. Another famous coronavirus, the Middle East Respiratory Syndrome, also has caused acute disseminated encephalomyelitis, cerebrovascular diseases, and Bickerstaff's brainstem encephalitis. So it is quite natural for us to suspect that SARS-CoV-2, the virus that causes COVID-19, may do some of the similar things. Let's talk about some of these severe syndromes that we can see in other and possibly this pandemic. Acute necrotizing encephalopathy, or ANE, often follows an acute febrile illness, typically by a virus. Even though most of the cases reported are coming out of Japan and Taiwan in previously healthy children, this can happen worldwide. Typically, patients have fever, either a respiratory infection or some sort of gastroenteritis, followed by seizures, disturbance of consciousness, and then rapidly progress into coma. The most commonly associated viruses are influenzas A and B and human herpes virus 6. There is a familial form of this, and it's associated with a specific genetic mutation. And to date, at least of 2020, 59 cases have been reported worldwide. There's no treatment for this. People have empirically tried corticosteroids, anti-cytokine therapies, but outcomes are generally poor. On the right-hand side, you can see this MRI showing both bilateral thalami, an organ that's of very high importance in consciousness and arousal in a patient, are involved in this disease with evidence of edema. Here's the rostral pons. Brainstem, another very important structure for consciousness and most neurological functions. And this image here, D, E, and F, shows the destruction of the tissue and the thalami and the bleeding into this tissue in necrotizing encephalopathy. A more common problem, acute disseminated encephalomyelitis, or typically called ADEM, is a brief but widespread inflammation of the brain and the spinal cord, typically involving the white matter or nerves that are covered by myelin. It usually follows either a viral or bacterial infection, but in rare occasions can follow vaccination from measles, mumps, and rubella. The presenting symptoms are fatigue, headache, nausea, vomiting, and patients can develop vision loss, hemiparesis, ataxia. In severe cases, they could be in a coma. This affects children more than adults, young adults more than old adults, typically are treated by high-dose corticosteroids, and the prognosis is typically good, although in severe cases, this can be fatal. And also of note, this can happen again. And the image on the right-hand side illustrates sort of typical MRI findings for this condition. The original SARS-CoV virus is known to cause brain injury. Here is a case report of a 39-year-old physician who was working on the SARS ward. He originally developed the classic SARS symptom, was empirically treated by ribavirin and methylprednisolone and got better. But at week 4, his symptoms worsened again, and he developed neurological symptoms including vision loss, dysphoria, vomiting, delirium, and progressively, he also had worse pulmonary infiltrates, leukopenia, and bone marrow depression. By day 33, he fell into a coma, was transferred into the ICU, and intubated. As you can see on the right-hand side, his brain CAT scan shows diffuse cerebral edema, enlargement of the ventricle suggesting of hydrocephalus, loss of gray white differentiation. This looks like a brain that is either herniated or is about to herniate. And voila, at day 36, his brain herniated and he passed away. Post-mortem, they were able to detect fragments of the SARS-CoV virus in his lung as well as in his brain tissue. And here's an electron microscope of brain tissue identifying viral particles in his brain, suggesting the SARS-CoV virus can indeed invade the brain. What are some potential etiologies for CNS involvement in COVID-19? The most dreaded one that we all think about is direct viral invasion, so the attack of the virus directly onto brain cells. A good example of that is the West Nile virus, which attacks the brain cells and neurons directly. A bigger, more common problem would be para-infectious immune-mediated, such as ADEM, as we've discussed, transverse myelitis, and the famous Guillain-Barré syndrome. We can also have neurological complications of systemic disease caused by COVID-19. For example, the hypercoagulability can lead to ischemic strokes. The hypoxic respiratory failure can cause hypoxic brain injury, and of course, severe sepsis, causing encephalopathy and delirium. One class of patients have exacerbation of baseline neurological disorder. For example, patients with epilepsy may experience worse seizures, develop into status epilepticus if they're infected by COVID-19, and multiple sclerosis patients may experience a worse flare. And finally, the treatments, the therapies we use are not risk-free. The anticoagulants we use can cause hemorrhages. The steroids and the paralytic medications puts patients at higher risk for critical illness, neuropathy, and myopathy, and of course the sedatives linking to delirium and encephalopathy. The last category may not have a direct pathological association with SARS-CoV-2 virus per se, but is in the spectrum of neurological syndromes that we can see. Back in April 2020, a famous New England Journal paper that reviewed some of the early neurological syndromes suggested that even though we can have neurological signs, we can see findings on brain MRI in 7 out of 7 patients who have cerebrospinal fluid examination because they have neurological syndromes. They were not able to detect SARS-CoV-2 virus in the CSF. Now, this doesn't mean that SARS-CoV-2 is not in the brain. It may simply mean that we are unable to detect it in cerebrospinal fluid. But this is different from the other viral pandemics that have influenced the central nervous system. Earlier, we talked about necrotizing encephalopathy. Back also early in the pandemic, there was a case report of such. A 50-some-year-old airline worker developed classic COVID-19 symptoms and then progressed into coma and had altered mental status. Her cerebrospinal fluid was negative for the common viral pathogens that may cause this. You can see on the screen here, the thalami are swollen, but the veins and the arteries are open, suggesting this is not a vascular etiology. And on brain MRI, we see the classic signature of necrotizing encephalopathy. At the time this case report was published, the patient was still very severely ill, and we do not have information on what the long-term outcome is. There has also been emerging reports of ischemic stroke, and I encourage you to listen to Dr. Claude Hempfield's talk following mine, where he would dissect further into ischemic strokes. But be that as it may, I will talk to you about the first report coming out in April 2020 identified that of all the patients who had strokes, the symptoms can start up from 2 days before they had the classic COVID-19 symptoms, all the way to almost a month out. And in this case report, at least, all of these patients had at least moderate to severe, if not severe and critical, COVID-19 symptoms, suggesting that stroke might happen in the patients who are more severe. Following this, a case report came out of Mount Sinai Hospital in New York, where they identified young patients with no risk factors for stroke coming in with severe strokes with large vessel occlusion. And this table summarizes their possible any pre-existing conditions. The most important thing from this table for me is that 2 out of the 5 patients have no classic COVID-19 symptoms, one of whom was screened only because there was a positive contact, and the next patient had no symptoms whatsoever, suggesting that stroke could be the presenting symptom of COVID-19 in a patient. There are now beginning to be pathological studies where patients who passed away have their brain examined on autopsy. And in this case series that came out in June, as you can see, by far the most dominant finding is acute hypoxic ischemic damage. Not surprising given COVID-19 has severe pulmonary influence. Also now in press, a case report, or actually a case series coming out of 3 major centers from China with a total of 917 patients, suggested that the most common symptoms in COVID-19 neurological manifestation might be delirium, drowsiness, stupor, and coma. If we look at the single case reports to date, by far the most commonly reported neurological syndrome is Guillain-Barré, followed by ischemic stroke and encephalitis. However, with all the case reports and case series, what we don't know still is what exactly is the prevalence of the manifestation of COVID-19. In order to calculate that, we need a reliable denominator. That is a challenge, at least here in the United States, because we don't have widespread testing. So we actually don't know what is the community rate of actual COVID-19 prevalence, or at least SARS-CoV-2 positive people in the community. We also don't know still what are the main neurological manifestations of COVID-19. We don't know if these symptoms are caused directly by the SARS-CoV-2 virus, or do they occur by coincidence? And finally, and most importantly, what does this mean for outcome of a patient with neurological manifestations of COVID-19? And what are the risk factors? How can we figure out which patient is going to develop these feared neurological symptoms? To address this, we have developed the GCS NeuroCovid Consortium. This is an international global consortium, and we've since partnered with other big global networks. So for our consortium, currently we're at 218 sites with 123 of adult sites and 96 pediatric sites with the investigators listed here, including myself. The Central Coordinating Center is at my university, the University of Pittsburgh. We're very honored to be able to collaborate formally with the European Academy of Neurology in their Energy Study Network, which now has more than 230 sites across primarily Europe and Africa, but with a global reach. The Latin American Brain Injury Consortium, LABIC, and possible network in Latin America. This is a nice schematic of our global outreach as of July 1st. And as we speak, we have ongoing data harmonization efforts with many, many large entities globally, including the WHO. And with this, I would acknowledge all of the key members of the consortium and close the talk for questions. Thank you very much.